Good afternoon, everyone. I'm pleased to present my PhD topic, the impact of navigational system on CT-guided intervention. My name is Mátyás Rédei. I'm from a medical imaging center. And throughout my PhD research work, I would like to improve CT-guided interventions with advanced navigational systems. And the mission to aim this vision is to explore, implement, and optimize advanced navigation in CT-guided interventions. We aim three specific goals in the first year of my PhD studies. First of all, we would like to investigate different types of navigational systems in different clinical scenarios. Secondly, we would like to complete these interventions with peri- and post-procedural maneuvers. And lastly, we would like to investigate the impact of our self-developed navigational system. First of all, we are investigating the safety and effectiveness of navigational systems for patients undergoing CT-guided interventions. There are various types of CT-guided interventions, each with distinct characteristics, which make their comparison challenging. However, they share a common initial part, the needle insertion part. The success of this intervention hinges on the precision of the needle insertion. And without navigational system, this needle insertion is very time-consuming and need multiple needle manipulation, which can cause more complications and even increase irradiation dose and cause long waiting lists. However, by utilizing navigational systems, this radiation can be decreased by half. The procedure time can be decreased with more than 30%, and the complications can be reduced almost with 7%. So our aim is to assess the safety and effectiveness of these navigational systems to enhance patients' outcome. Therefore, we are comparing the utilization and non-utilization of these systems in patients undergoing CT-guided intervention to assess outcomes such as number of needle manipulation, procedure time, and irradiation dose. And we hypothesize that the system improves efficacy and safety in these interventions. We conducted a systematic search with the search key shown above, and after the selection, we managed to include 36 articles into the analysis. So let's jump to the first outcome parameter, number of needle manipulation. As I mentioned, the success of this intervention hinged on the precision of the needle placement. And to reach this, we have to manipulate the needle during this intervention, which can lead to multiple complications. Therefore, less needle manipulation is generally preferable. We included 19 studies with over 2,000 patients, and we observed great heterogeneity throughout all of my outcomes. Since there are various types of interventions, the skill of the involved radiologists are different, and even the targeted organs are different. However, despite this heterogeneity, we observed significant reduction of number of needle manipulation during this intervention, which can also almost reach 3 by procedure. The second outcome parameter is procedure time, which is critical when it comes for patients' comfort and healthcare efficacy. First of all, we included 19 studies with around 2,000 patients again, and this outcome parameter is connected to number of needle manipulation because that can also lengthen the procedure time. We observed great heterogeneity as well here, and we can see that there is a tendency to lower these procedure times with the utilization of navigational systems, and to have deeper insight into this intervention, we created a subgroup analysis based on the type of the interventions. For above, you can see the thermal ablation subgroup, where we can see a significant reduction by more than 12 minutes in these procedures. Usually these procedures are longer than in the other subgroup, the biopsy subgroup, but these minor reduction is also clinically highly relevant. However, in the biopsy subgroup, where the biopsies usually takes about 20 minutes, we observe a reduction of 5 minutes in each in this subgroup, which is clinically highly relevant. The third outcome parameter is irradiation dose, which is also really important, especially in repeated CT-guided interventions. And with 20 studies with around 2,000 patients, we observe a significantly lower irradiation by utilizing navigational systems. Lastly, I would like to present the success rate, which is very critical factor with CT-guided interventions. The technical success rate, when you can observe on the CT scan that the needle or the antenna is placed correctly, is significantly, the odds ratio of the technical success rate is significantly higher in the navigational system group. And the diagnostic success rate, the histopathological positiveness of biopsy, is also significantly higher in the navigational system-assisted procedures. So our conclusion is that navigational system in CT-guided interventions boost efficacy, accuracy, and also reduce complication by minimizing needle manipulation. And for practice, we suggest that these systems should be used during these interventions. And for further implication for research is to compare different type of navigational systems and identify the best ones for specific interventions. The strength of our study is that it has practice-changing potential and is clinically highly relevant, and we can also provide recommendation when and how it is beneficial to use navigational systems, although the applicability of the result is a limitation because we cannot separate the different type of and different devices of navigational systems. So now we are at the stage of manuscript writing. We have to discuss some plots more, and we are targeting the Journal of Investigative Radiology. The second project of mine is comparing complication rates per protocol versus standard method in CT-guided pulmonary biopsies. Regarding lung malignancies, the histopathological diagnosis can be critical for treatment. The decision between transbronchial and percutaneous CT-guided biopsy is usually depends on the localization of the lesion, because peripheral lesions are usually goes under percutaneous CT-guided biopsy. This technique has nearly 100% of technical success rate and also around 90% of diagnostic accuracy, and it can be conducted under local anesthesia. However, on the other hand, we have to mention that it has high complication rates, especially pneumothorax rates, which can reach also almost 40%, and even with around 5 to 10% of chest tube insertions. To lower these complications, we can utilize navigational systems, and also we can use per protocol, which is a collective name of peri and post-procedure maneuvers: patient's positioning biopsy side down, needle removing during expiration, autologous blood patch sealing, rapid rollover, and pleural patching. There is a study conducted, a cohort study conducted previously, where they observed lower pneumothorax rate and also a significantly lower chest tube insertion with the same diagnostic accuracy. So we are comparing the per protocol with the standard technique with patients undergoing CT-guided lung biopsy to assess rates of pneumothorax and chest tube insertions. And the clinical implication is to implement this protocol in our everyday clinical practice. And I would like to end my presentation with an inspiring quote: "Innovation is the calling card of the future." Thank you for your attention.
Let me start. When you say regarding your first project that the applicability is a limitation. I mean, that is a serious limitation. How will you tackle that in your manuscript?
We are trying to manage to tackle, because there are some articles where it's not clearly described which kind of a device are they using. I mean, not the type of the device, but the special device they are using. So it's a hard limitation in this study.
Mm-hmm. And how would you solve that problem in the future?
It's a tough question. If I would conduct an RCT to be eligible for meta-analysis, I would...
Yeah, but how would you fine-tune the methods to overcome the limitations of the studies you included?
Maybe there is a way to group them by the type, by if it's stereotactic, if it's inertial measurement unit-based or electromagnetic-based, but there are different types in between, but we can categorize them also, so it can be a solution to the applicability problem.
Yeah. Okay. Any further questions?
Nice presentation, thanks. I'm mostly familiar with CT-guided lung biopsies. Did you do the organ-specific analysis? So that is on your first project, like liver versus lung versus I don't know what?
Usually liver biopsies are conducted under ultrasound guidance, so that makes the comparison impossible with CT-guided. We have organ-specific outcome for diagnostic success rate, since it's usually applicable. It's just applicable for lung biopsies, and on that plot, I included just pulmonary biopsies. And we observed 1.83 odds ratio in diagnostic success rate with navigational systems. And we also have some plots, which I haven't included here due to lack of time, with subgroup analysis of thermal ablation in lung, and also chest tube insertion. And the pneumothorax rates are also assessed with lung specifically, and we observed that the pneumothorax rates are similar, but the chest tube insertion is significantly lower in the case when utilizing navigational systems, and it's also true for thermal ablation of the lung lesions.
Is it possible to adjust your analysis for operator skills?
It's really hard, since it's kind of subjective how we assess the operator skills. So you can assess that 3-year, 5-year, 10 years of experience, or you can assess that 100 procedure, 200 procedure, 300 procedure. With the included studies, we had 36. I had only found 2 articles where they describe skills as resident and and an experienced operator. So that would be really nice. And we are also planning to compare navigation-assisted, less experienced operator with experienced operators without navigational systems.